second section will be on appropriateness of the transfusion practices during non-routine hours in transfusion medicine. It will be led by me myself, Dr. Ashwin Mohan, transfusion medicine senior resident. And the first session will be chaired by me, and the second, and vice versa. The second section will be presented by me and chaired by Dr. Pradeep Banerjee. And Dr. Mohit Gupta from Neurosurgery department is here to help us with the case which we are presenting. So once again, I welcome you all to the section, and I welcome Dr. Pradeep to do his first section on incident reporting in Department of Transfusion Medicine.
A very good morning to all present here. The topic for today's CGR presentation is incident reporting in the Department of Transfusion Medicine, AIIMS Rishikesh. So first of all, what is the quality policy of our blood bank here at AIIMS Rishikesh? So at our department, our aim is to provide an adequate, sustainable supply of blood components wherein we provide the right blood component to the right patient in the right quantity at the right time while conforming to all the quality requirements for the same. So since the inception of our blood bank in 2015 till the end of 2022, so we have issued almost 170,000 units so far, the mainstay being packed red blood cells, fresh frozen plasma, random donor platelets, cryoprecipitate, and as newer requirements for newer blood components came into action, we developed newer components as well, like single donor platelets, COVID convalescent plasma during the pandemic, peripheral blood stem cells. So this is a graphical representation of our year-wise blood components issued, wherein we can see there is a steady rise in the transfusion requirements year-wise, except the 2020 year in which we were hit by the pandemic. So with the ever-increasing load and ever-increasing issues of blood components, there is every chance that we might make a mistake. So it might be multifactorial, and I would like to discuss our experience on these kind of mistakes. First of all, what is an incident? Before that, what is an error and an accident? So an error is an unplanned deviation from the hospital policies or the standard operating procedures, which may be due to human factors or a system problem, whereas accident is an unplanned occurrence which is not due to any deviation from policies or SOPs. It's an accident in true sense. So due to such an error or an accident which may lead to an adverse outcome is known as an incident. It might affect, in this case, the safety and quality of our blood components or the safety of the blood donor or the recipient. Now, what is the fate of such an incident? It can have a number of fates. First of all, it can lead to a near-miss event wherein an incident is discovered before the start of a process which could have led to an adverse outcome. For example, if a wrong blood is issued to a patient and we discover that before the start of the transfusion and prevent it, then it is a near-miss event. Whereas a no-harm event is an incident which is discovered after the start of the process but did not have an adverse outcome. Suppose if the wrong blood is started to be transfused to that patient but no adverse event occurs, then it is a no-harm event. And finally, an incident may lead to an adverse reaction which is an undesirable outcome. For example, a transfusion reaction in a patient, but it may or may not be due to an incident. So once such an incident occurs, how do we manage it? First of all is the prompt detection of the incident followed by the remedial action. Now remedial action is the immediate steps that we take to alleviate the symptoms of that current undesirable situation. For example, during a transfusion reaction, stopping of the transfusion and informing the blood bank is the remedial action during that situation. It will be followed by incident reporting and investigation, which go in hand. While investigating an incident, we use the Ishikawa diagram or the fishbone diagram for root cause analysis of the problem, wherein the problems are classified under the famous 5 M's: material, method, machine, mother, nature, and man. For example, if a faulty component is prepared, the problem might be due to the material. For example, the blood bags used, or might be due to the method of phlebotomy or the method of component separation. It might be due to machine factors like a faulty centrifuge or a faulty blood collection monitor. Might be due to environmental factors like subjecting the component to extremes of temperature, or might be due to human errors like improper skills. So after we find out the root cause, we take the necessary actions to prevent the occurrence and recurrence of the problem, which may be a corrective action or a preventive action. Now, a corrective action is the action which will address the root cause of that incident, and we will try to eliminate it so that it doesn't recur in the future. Whereas a preventive action, it's a proactive action. It's a proactive approach wherein we eliminate the potential of such an incident to happen again in the future, and wherein we prevent the occurrence again. So there are a number of quality tools for problem solving, as we have seen in the last slide. So we can have a checklist of various things that we need during a process, frequent brainstorming sessions, or the fishbone diagram that we've seen in the last slide, all of which will lead to a solution. So now I would like to share our experience with the incidents that we have over the years. So from 2018 onwards, we started a system of rigorous incident reporting and taking the following corrective and preventive actions as necessary, which saw 21 incidents being detected in 2018. And due to this policy of rigorous implementation of incident reporting, we can see there is a rise in the number of incidents to 27 in 2019. This was because we tried to detect even the smallest errors, and so the number seems large. But in the later years, as we took the corrective and preventive actions for those incidents, we see there is a decrease in the number of incidents. But in the year 2020 or 2021, the number of incidents being 9 might be due to the pandemic as well. But in 2022 as well, we have 13 incidents only, which is much lesser than the previous years, which points towards the correct preventive and corrective actions in play.
Like how many transfusions and how many days that was in the form of a percentage? In this chart, what is the denominator of 21, 27, 9? We need to know that.
Ma'am, these are the incidents which are not only related to transfusion, but also the laboratory practices that we are doing in our lab.
What's the denominator? Like you showed in the first slide. Number of transfusions per year, is that the denominator?
That plus
Number of-
overall
and-
incidents, which is coming in the next slide. This is the absolute
Number, but what's the denominator?
number.
No, the number of transfusions done and the incidents reported.
Ma'am, these are just the numbers wherein each.
First slide will tell
First
how many
slide,
transfusions.
numbers there.
Chalo, we wanted to see, you can show it in this particular. Let's go ahead. Doesn't matter. We need to know how many transfusions were given.
Ma'am, a total of 1,70,000 transfusions were given from 2015 onwards, ma'am. And every process, be it transfusion or the laboratory practices that we are doing, wherever there is a deviation from policies or an adverse event, we are counting that as an incident. Out of the 79 incidents that we have detected since 2018, almost 20%, that is 16 incidents were interdepartmental, wherein other departments were also involved, and 80% of them, that is 63, were intradepartmental. It seems like a huge number, but we tried to detect even the smallest of the errors, like breakage of a test tube in a centrifuge or even a blood spill. But today I will be discussing about all the incidents in which other departments were also involved. This is not to inculcate a blame culture, wherein we are pointing towards the mistake of others, but to inculcate a quality culture, wherein with the help of the other departments, we find out the actual problem and then deal with it. So wherein the quality of our products and the services that we are providing are maintained. First of all, we'll deal with the incidents wherein we received an improper sample or a request form. The most common of them was a wrong blood in tube. Here the corrective action was to get a properly filled form and a new sample with every request form that we received. And as a preventive action, we stressed on the importance of correct patient identification, whether be it bedside or whether be it in the blood bank. Next up is an incident wherein the policy of proper filling of forms and sending of samples was not followed, where we received an FFP request which was without the name of the patient or the gender of the patient, and also the blood sample was also not sent. So as a corrective action, we requested the sample to be sent with the properly filled blood request form, and as a preventive action, we stressed on the importance of such a thing, proper labeling of samples and proper filling of forms with all the information, so that we can be clear about the indication of transfusion and also correctly identify the patient who will need the transfusion. Next up is a case wherein an incorrect previous blood group history was reported in the request form. As a corrective action, we rechecked the previous history, and also we got the resampling of the patient done so that there is no mix-up. And as a preventive action, we stressed on the importance of rechecking the previous history of every patient, be it in the bedside or from the side of a blood bank. So the serious hazards of transfusion study, the short study UK, they have been classifying all these errors and incidents and trying to elucidate all the reasons associated with it. So in the 2014 reports, the most common reason for a wrong blood in tube was the patient being not identified correctly or the sample not being labeled at the bedside. So we have been facing similar problems in our setup as well. The next is an incident regarding blood issue, wherein there was a delay of issue of the blood component due to an improper handover. As a corrective action, we got the blood unit immediately issued, and as a preventive action, we started a system of proper handwritten documented handover rather than a verbal one, wherein it's very easy to forget things. Next are the incidents related to blood administration. The first two of them were regarding the presence of a clot in the bag, wherein the corrective action taken was to discard that unit and get a new unit issued for the patient. And preventive action was adequate staff training for better phlebotomy practices, better component handling practices, so that such an incident doesn't happen again. The next was a blood flow issue, wherein the IV access of the patient was not patent. We inspected the unit for visually for clots, but we didn't find any. And then we got communicated that the IV access had a problem. And as a preventive action, we stressed on the importance of maintaining a patent IV access before every transfusion. And the next is an improper storage of blood in the ward, in the refrigerators that are there in the ward, which led to incorrect patient identification due to mixing of the units in that refrigerator. As a corrective action, the correct intended unit was finally issued to the patient and transfused. And as a preventive action, we scheduled ward visits and appropriate training of the nursing officers and all the stakeholders involved in a transfusion for better transfusion practices. Next was an incident regarding an uninformed adverse transfusion reaction, wherein a febrile reaction was there in the recipient and the unit was discontinued, but then again it was resumed after 12 hours, which resulted in another febrile episode. As a corrective action, we did the immunohematological workup of the adverse transfusion reaction and we found no abnormalities. And as a preventive action, we scheduled training sessions for better transfusion practices. Next was a blood administration mistake, wherein the transfusion was started 6 hours after the issue of blood, which should have been started within 30 minutes and completed within 4 hours of issue. This led to a febrile reaction in the patient. Then again, as a corrective action, we did the adverse transfusion reaction workup and found no immunohematological incompatibilities. And as a preventive action again, we advised training sessions for better transfusion practices. The next two incidents are regarding incorrect patient identification, wherein the root cause was, in the first one, the blood units of two patients with the same name in the same ward were mixed up. So as a corrective action, the transfusion was immediately stopped. We received the bag, we confirmed the cross-match of the two units with both the patients, but then again we discarded the unit because the transfusion time had elapsed. And in the second case, two patients of the same name were there at the same time where the request form was being processed, and due to which the incompatibility issues of one patient, it was wrongly conveyed to the other patient, which was in the OT and immediate need of transfusion. As a corrective action, we issued immediately the blood unit required to the patient in the OT. And as a preventive action, we started patient identification by using not only the patient name and UHID, but also other identifiers as well, such as the place of residence or phone number, which is generally unique to one individual. And the last incident was regarding seroconversion of a blood donor, wherein in the previous blood donation, the donor was TTA negative for all the transfusion transmitted infections, and in the next donation 1.5 months back, wherein he came to donate a single donor platelet, he came out to be HCV reactive. As a corrective action, we informed all the consultants about the recipients of the previous blood components that had been issued, and we followed up those recipients and no one came to be HCV reactive following the transfusions. And also the donor was referred to gastroenterology. As a preventive actions, we put forward an option of universal NAT testing or nucleic acid testing so that we reduce the window period as much as possible. Also, we stressed on the importance of eliciting proper donor history, which would in turn inculcate hepatitis awareness in the community. So the short reports of 2014, they tried to find out what are the mistakes that led to a wrong transfusion. So an improper request was, the number of improper requests was 108 and sample taking problems were 686 which were mitigated then and there itself. And all the laboratory errors relating to the incidents, which were almost 250 in number, and also blood component restriction and blood component administration related problems were also of a huge number, 140 and 162 respectively. And also the short study in UK in 2014, they also classified the adverse incidents which were made due to mistakes. So we can see a multitude of problems wherein incorrect blood component transfusion anti-D related errors and handling and storage errors of components were the highest. So after such data available to us and all the experience that we had over the years, we couldn't agree with Eleanor Roosevelt more that we should learn from the mistakes of others because we can't live long enough to make the mistakes all ourselves. And if we have this policy in mind, we can move towards the goal of total quality, wherein not only addressing the problem and finding out the root cause and addressing it then and there is a solution, but also continuous improvement towards all the preventive actions that we are taking. Whether it can be improved or not have to be kept in mind. Now, in order to summarizing all the corrective actions and preventive actions that we discussed earlier. So, for a wrong blood in tube, the preventive action would be a correct patient identification using as many identifiers as possible. And for improperly filled forms or without a sample, the preventive action would be proper filling of the forms with each and every information and proper labeling of the samples. And for incorrect patient history that is sometimes mentioned in the forms, as a preventive action, we should always check the previous history of the patient, be it bedside or be it in the blood bank. Or in cases related to delay in issue of blood components due to improper handover, as a preventive action, there should be a written document handover at any instance of duty change because verbal things are very easy to miss and forget. And in case of a TTI reactive repeat donor, we can put forward an option of universal nucleic acid testing. We should elicit adequate donor history and provide awareness to the community regarding hepatitis and other transfusion transmitted infections. So this is a picture of our sample or blood request rejection form wherein any improperly filled request or any improperly labeled sample is returned back to the ward with the appropriate reasons. And this is a picture of our handover register wherein all our residents and technicians, they write down the handover that are to be given to the next duty person and not relying just upon verbal communication. Next up, wherever there is a clot in the bag, as a preventive measure, we inculcated staff training periodically, like quarterly or monthly trainings regarding good phlebotomy practices, good component handling practices, which would prevent such an error. In cases where there was a complaint of blood flow, as a preventive action, we started a culture of visual check. The visual check at the moment of preparing the component, storage of the component, testing of the component, and also issue of the component at these 4 points, and also proper maintaining of the IV access patency before the start of a transfusion. And in cases where improper blood storage in the ward refrigerators led to the mix-up of units, as a preventive action, schedule ward visits and regular trainings of the stakeholders of transfusion, be it the nursing officers, be it the JRs or the interns, regarding good transfusion practices. And in cases where there was an uninformed adverse transfusion reaction, and in cases where transfusion was started 6 hours after the issue of a blood unit, which led to an adverse transfusion reaction in that case, as a preventive action, we suggested training sessions like monthly or quarterly or 6 monthly. And in incidents where blood units of patients are being mixed up in the same ward due to same name or same credentials, we stressed on the importance of correct identification of the patient using as many identifiers as possible. So this is the picture of the training sessions that we had in the past. Now, some take-home messages that I want to give at the end. So each step in this blood delivery pathway is very critical, and we should identify the areas of highest risk of mix-up. For example, bedside patient identification. Now, so however urgent the transfusion might be, we should follow each and every step because it is critical, and this will prevent a patient from a fatal transfusion reaction because lives here are at stake. And finally, even after all the precautions that we take, even after an incident has happened, we have to deal with it properly. Report it as quickly as possible, perform a root cause analysis, find out the actual cause and address it by corrective and preventive actions, and not only stop there, but also to monitor the system. This will ensure continuous quality improvement and better transfusion practices. Thank you. I would like to invite Dr. Ashwin here. He will continue with the presentation and will discuss a case regarding appropriateness of transfusion. And I would like to invite Dr. Mohit as well. He would be chairing this session with me. Thank you.
Good morning all. as my colleague Dr. Pradeep discussed, he was discussing about the adverse events and adverse transfusion reactions which can occur in transfusion practices. So in many studies which was conducted throughout the world, it was found that all these manual errors and all which he was discussing, the chances of such errors are more during night time. So my topic for CGR is appropriateness of transfusion practices during non-routine hours. So basically it is from 5 p.m. to 8 a.m. in our department. So coming to the background of this discussion, all these points will be discussed in the coming slides. The transfusion decision should be evidence-based. Sometimes blood demands are received that may not considered appropriate. Non-routine hour transfusion should be restricted to emergency cases, and non-emergency transfusion increases the workload of the blood center, and regular auditing of the non-routine hour transfusion may be helpful to improve the hospital transfusion practices. So I will be presenting a case. So this case is a case of 74-year-old male patient with SDH who came to our emergency and had to undergo emergency craniectomy, and the patient was on anticoagulant therapy. So multiple blood units like FFP, PRBC and cryo had to be transfused to the patient, and we were able to provide all those blood products, and with that blood products the neurosurgery team was able to do proper surgery, and which helped in better prognosis and better quality of life for the patient. So coming to the case, a 74-year-old male patient presented to emergency on 28/11/2022, 12:30 a.m. with complaints of multiple episodes of vomiting associated with sweating and uneasiness, followed by irrelevant talking, abnormal behavior, and finally unconscious. The patient was intubated in emergency department in view of poor neurological status and risk of threatened airway. Then coming to the past history of the patient had a history of visit to AIIMS emergency department 26/11/2022, few days back only, following an episode of chest pain, unconsciousness and fall at home, for which he was admitted to cardiology SDU in view of episodes of intermittent atrial fibrillation. The NCCT head was done during the previous admission on 26/11/2022 in view of loss of consciousness, which revealed only scalp hematoma with no intraparenchymal bleed or skull fracture. The patient underwent coronary angiography, which revealed double vessel disease, and continued on optimal medical therapy and anticoagulation for atrial fibrillation, which included aspirin and apixaban and statins. The patient is a known hypertensive diagnosed with lymphoma in 2011, treated with R-CHOP regimen, currently in remission. On general examination, the pulse rate was 102 beats per minute, BT was 160/90 mmHg, respiratory rate 24 per minute, temperature febrile, respiratory system bilateral, chest clear, CVS, S1, S2 head normally, no murmur were present, per abdomen soft, no palpable organomegaly, bowel sounds were present, CNS E1, B1, M5, and on intubation on emergency it became E1, BT, M5, and pupils were bilateral 3 mm reacting to light. Power moving all four limbs against gravity. On investigation, the HB was 13.2, TLC 11,600 cells per millimeter cube, platelet 2.82 lakh per millimeter cube, and PTNR was 10.9 and 1, and all other LFT and KFT parameters were within normal limits. Then coming to investigation, the urgent CT scan was done, NCCT was done, and it suggested fresh left frontotemporoparatal acute SDH with mass effect and midline shift. Urgent left frontotemporoparatal decompressive craniotomy was planned. So this is the CT scan of the patient. So here you will be able to see the collection, hyperdense collection, and it is causing a midline shift. So that was the SDH. And so why the transfusion was required to the patient? Because the patient was on aspirin, which caused functional dysregulation of the platelet aggregation, and on apixaban, which is a factor 10A inhibitor, and do not have these two medications, that is aspirin and apixaban, do not have any specific drug causing a reversal of its action, except only remedy is to wait for 48 to 72 hours for the surgery, which was not possible in our case due to rapid deterioration of the neurological status of the patient. So out of the different prerequisites needed for the OT, blood products were one of the important ones, and since the patient was on anticoagulant therapy, adequate transfusion of platelet, FFP, PRBCs and cryo was planned during the night hours itself. So these are the list of the blood products which were arranged for the patient: 7 FFPs, 2 adult platelet doses, 6 cryoprecipitates and 3 PRBCs. Then this is the prognostic marker for outcome of an acute SDH. So here we can see out of the 7 markers, almost 5 is against the patient. So patient age was more than 60, GCS was less than 8, the patient was on antiplatelet medication, and thickness of the hematoma and midline shift was there. The thickness was 11 mm and the midline shift was also there. And the coming to comorbidities, the patient had hypertension. So all these 5 parameters were against a good prognosis for the patient, and the duration of the test was less than 6 hours and anisocoria was absent. So only these 2 parameters were in support of a good prognosis for the patient. So the operation happened, the craniotomy happened, and all those blood products were transfused. And in post-operative day 1, the patient improved to GCS of E3-VT-M6 with minimal paucity in right upper and lower limb. In post-operative day 2, the patient was extubated and improved to GCS E4-V4-M6 with slurring of speech. Cardiology opinion was taken and tab amlodipine and tab atorvastatin and metoprolol were started, and gradually improved to conscious oriented following commands, ambulatory with minimal support, occasionally with normal speech with gradual improvement in paucity of right upper and lower limb, and got discharged in a satisfactory condition with follow-up advice in 6/12/22, that is day 8 of admission. So this is the repeat CT after the surgery. So here you can see post surgery the defect on the craniotomy, and also the SDH and the midline shift has also disappeared. So even if the patient was having a bad prognosis, with timely transfusion and timely acting by neurosurgery team, the patient had a better quality of life and good prognosis. So the question here is this an appropriate transfusion in the night hours? And as you all know, the answer is yes. Why? The rationale behind and was on anticoagulant, hence the transfusion of the blood products at the earliest was of utmost importance to start the surgery, which resulted in a better prognosis. So when I came through this case, I went through, I decided to assess the effectiveness of the transfusion during non-routine hours. So I investigated into a few modalities of transfusion. So first one was CT ratio. So I checked the CT ratio of PRBC units issued during non-routine hours for 1 year time period. So CT ratio means the number of units cross-matched by number of units transfused. So it will be finding if using this modality, we will be finding out if unnecessary cross matches is being happening. Like we are arranging the blood for the patient and it is not getting transfused. So the total number of units cross matched in one year time period was 11,030, and total number of units issued during non-routine hours were 8,457. So the CT ratio was coming around 1.30. So this number of CT ratio was almost good, because almost all the blood products which are arranged for the patient is getting transfused also. So this is reasonably good CT ratio. So I further investigated into the appropriateness of the request form which I am using. Like I went through all the request forms, what is the diagnosis and how many blood units have been arranged. So when I investigated into it, it is a data of non-routine hour transfusions in AIIMS Blood Center for 1 year time period. So total unit arranged in a year during day and night, like during routine and non-routine hours, were 44,053, out of which almost 51.68% of the workload was coming on non-routine hours, that is from 5 o'clock to 8 o'clock. So you can see that a huge workload is coming during non-routine hours on our staff, and out of this 22,770 the units arranged in non-routine hours, 73% were for appropriate indications and 27% were for inappropriate indication. You can see in the graph, almost 73% is for appropriate indication during non-routine hours, and 27% were inappropriate indications for non-routine hours. So the problem is this 27% will delay the transfusion happening for this 73%. So during this non-routine hours, almost each and every request will be an emergency, like the case which I discussed, and those patients should get transfusion at the earliest. So when such inappropriate indicated requests are coming, it will delay the transfusion for the 73% of patients, and it may affect the prognosis and quality of the life of those patients. So when I analyze the number of requests, on an average we will be receiving almost 25 requests per night, like during non-routine hours, and out of it 7 were inappropriate, and that means every 4th request during non-routine hours is inappropriate. So that indirectly means every 5th request reaching the blood bank get delayed due to inappropriate request which preceded it. So what are the problems associated with inappropriate transfusion at non-routine hours? One is the delay in processing of appropriate transfusion, like the 73% and 27%. 73% transfusion will get delayed because of the 27% of inappropriate requests, and keeping extra manpower at night will suffer work of routine hours. The chances of error are high in night hour work, and extra work like workup transfusion reaction can come up, and issues related to blood donations are also a bit problematic during the night hours, which will indirectly affect the stock in the blood center. So this is a study conducted in New Zealand hospital. So what they did was all the red cell units transfused during the non-routine hours, that is from 8 p.m. to 8 a.m. were analyzed, and they came up with these findings. That is, adherence to recommended best transfusion practices were poor at night, because during the night time the healthcare workers were like not bit hesitant and all to give proper observation to the patient during transfusion. So the adherence to the recommended best transfusion practices were poor. 12% of the transfusions exceeded 4-hour recommendation. As you all know, a PRBC transfusion should end within 4 hours after onset of the transfusion. So in 12% of the transfusions, it exceeded 4-hour recommendation, and this may lead to unnecessary transfusion reaction happening. The end of the transfusion observation fell to less than 80%, and lowest complaints rate almost 69% occurred during early morning hours, that is 6 a.m. and all. In addition, they came to know that almost 4 transfusion reactions were reported, and when they questioned more detailedly, almost double this number, that is 4 transfusion reactions were reported, but almost 9 unreported reactions were there. So the problem with this unreported transfusion reaction is that if a patient is having a transfusion reaction, for the next further transfusion, the blood bank services will be doing some product modification, or things will be done. For example, if it is an FNHDR, we will be doing product modification like leucofiltration, or if it is an adverse hemolytic transfusion reaction, we will be careful when selecting the next blood unit. So when it is such reactions are going unreported, so it will affect our services, and it will lead to more transfusion reaction to the patient. And in many of the transfusion reaction, what happens is during a second episode of transfusion reaction, it can be more lethal to the patient. So I was analyzing the transfusion reaction data over 1 year time period in AIIMS Rishikesh. So total number of transfusion reaction in one year time period were 86, out of which 53 happened during non-routine hours and 33 happened during routine hours. Then this is a data from SHORT, that is serious hazard of transfusion. So this is a registry where all the adverse events happening with transfusion in UK will be registered. Whenever there is any adverse event happening, whenever there is any transfusion reaction happening, they have to report to this registry. So they documented that serious hazard of transfusion report of 2005 has stated that 37% of the transfusion error occurred during out of 4 hours. And according to that, the Joint United Kingdom Blood Transfusion and Tissue Transplantation Service Profession Advisory Committee in its transfusion handbook, in point number 4, safe transfusion, right blood, right patient, right time and right place, documents that non-essential out of our request for transfusion and overnight administration of blood should be avoided wherever possible because of an increased risk of errors. So, in order to conclude the CGR, in the presented case, the patient needed urgent transfusion and proper communication happened between the departments, and because of the transfusion, timely surgery happened and patient's life was end, and the patient had a better prognosis and quality of life. So, we would like to do same to each and every patient for that appropriateness of transfusion practices during non-routine hours is of utmost importance. Thank you.